All right, everyone, welcome. I'd like to let you know that if you are not on mute at this time, please do so. Note that Elena will help us through chat, and also you're able to unmute yourself. We'll explain that in just a little bit, but please note that there may be some background sound occasionally. We apologize for that, but if we can all do our parts, we'll have a great call. So good morning, everyone. I'm Mary Funseth. I'm a patient advisor at Superior Health Quality Alliance. And we at the Alliance wanted to provide for you something besides the work that we generally do with you during this difficult time dealing with COVID-19. The purpose of a call is for you to have a place to ask questions and also share ideas and gain some support from one another. We've had some very robust calls already, and we are starting to see some great value, and we are so thankful for all of you attending today. What this call isn't is that Superior Health, we're not the experts. We see you as the experts. We're here as navigators and supporters, and as our titles say, you know, we're advisors. But we're here to help you navigate your research in your search for answers. Each week, we have heard about challenges and successes, and we've shared back with you the great information that you've shared with us, and we've gone out and found some additional resources for you. We happen to have a web page where we have linked a variety of resources collected during these calls, as well as additional ideas that we found that we think will support you. During the call, you may experience some time when you won't hear anything, but note that, of course, people are thinking about the questions that we may ask you and or others will be asking. This is your call. This is not one for us to necessarily present anything to you specific. We want you to speak up and bring your thoughts forward. We do happen to have some guests on the call today representing telehealth, so we'll get to those folks shortly. But before we do get started this morning, we at Superior Health, we're very impressed. We are very thankful for all of you. And one of the things we wanted to do for you is simply do this. Superior Health, let's give them this. So know that we're here for you, and let's get started. This morning, we do happen to have telehealth on the line. So I'm going to let them introduce themselves briefly and tell us a little bit about how telehealth and COVID-19 connect.
Thank you so much for the introduction. This is Justin Duretzi, CEO with Theoria Medical 5-Star Telemed. So obviously everyone knows here on the call that over the past several weeks, the world has significantly changed both for acute and post-acute. Telehealth in the past has been seen as a transition oftentimes from physical rounding and from physical visits with a physician. And we, as we all know in the healthcare community, have seen some resistance at times with older patient populations and some skepticism in terms of receiving telehealth visits over the actual physical encounter with the physician. So I think that one thing as a culture in medicine in general that we've seen is a more of an acceptance of telehealth, both in the acute, post-acute, and primary care settings. So patients are a lot more willing to be seen by telehealth and actually are welcoming it and more than accepting it. Some patients are actually encouraging it, which is surprising coming from the older patient populations that we often deal with. In addition, we're seeing a lot more requests for telehealth visits from family members of older family or family members of older patient populations that we deal with. So family members want their loved ones to be seen via telehealth, where I think before the COVID-19 pandemic, we were seeing a little bit of resistance from families. Often statements being said that, well, a telehealth visit is not equal or the same quality as a physical visit. So some things that we've done on our end in terms of post-acute care and also primary care, in addition to after the transition from acute care, is a lot of our physicians are rounding via telehealth. So our physicians often visit multiple buildings in post-acute care. So in order to stop the potential spread of COVID-19 in an asymptomatic physician or someone who may be carrying it, we've been doing a lot more telemedicine. So I think that that is applicable in post-acute. We're also seeing an increase in the use of primary care physician visits with patients. And I think that the whole thing that telehealth has really allowed us to do is to deliver the same quality of care and the same concern as well as the same follow-up without exposing our patients to any further encounters that may expose them to COVID-19 unnecessarily. I think that post-acute, we're going to see an even further increase in the acuity and the sickness of the patients. And I think that telehealth allows us to continue to monitor those patients. And we will be opening a telehealth unit that is, well, a COVID unit that is run strictly by telehealth. Actually, today we go live. So we will be the first unit that is run strictly by telehealth, with the whole premise behind it being that we don't expose patients or healthcare workers to any unnecessary encounters with patients that are COVID positive.
Thank you, Justin. I'd like to open this. Let me open this up to the group on the call today. Those of you on the call, you may have some questions in this area. Please let us know what you may think and or need to ask. We'll give you a moment to unmute yourself. And also know you can put your questions in the chat. Elena, would you like to see if there's anything in the chat for this?
So we did just get a comment from Arlen Swanson, and feel free if anyone does want to verbally say anything or make any comments or ask any questions, feel free to unmute yourself using *6 if you're on the phone, or unmuting yourself on the Zoom by just hovering over your name. Arlen commented, we have been doing rounds with an iPad with Avera. And we Emlyn Howard, again, feel free to unmute yourself. I'm in the assumption that telehealth will include the required NP/MD visit for a SNP.
I'm sorry, I missed the tail end of it. You cut out. Require an MD or a PA or NP visit in what context?
For a skilled nursing facility.
So are they, is the question if they can do a telemed visit with an MD or an NP or PA in post-acute?
Lynn Howard, if you want to unmute yourself, or I can help you do that to kind of give some more context. I think that would be helpful in this situation.
Hi, everyone. This is Kevin Pozeshkin, COO of Theory Medical. Work closely with Dr. Justin Duretzi. I think, so the question was if it would constitute the required visits, and yes. So CMS did release guidance that clarified that yes, you can use telehealth to substitute for those in-person visits. So that is correct.
And I will say, everyone always, obviously everything is not always positive, and there's always not, it's not always just roses and butterflies. Some of the hardships that we faced is obviously staffing. So with the telehealth unit, if the physician or the PA or NP is not in the building, obviously someone has to man the telemed unit in order to bring it into the patient's room. So we have put in protocols and also feedback loops from the building to ensure that they're not being overwhelmed or stressed. And we've made it that we're doing telehealth visits during times that the either CNA or the nurse would be in the room typically as well, in order to not create another encounter or another in and out of the room unnecessarily.
Any others, Elena? And again, feel free to ask follow-up questions if you need to.
Hi, Mary. This is Eva with Superior Health. I just wanted to make a comment based on the 3 CMS calls that I joined just this week alone. There was a lot of questions about what constitutes a televisit. For example, if a doctor or physician is communicating through a iPhone video with a patient that's on the facility, if that should be billed as a telehealth versus inpatient, and the direction has been that that does not constitute a telehealth, it's an inpatient service that should be billed. You know, that the patient and the physician need to be in separate locations and a vicinity. So I just wanted to bring that up and see how any other organizations have been kind of running into this same question and billing issues.
Thanks, Eva. That brings up a good point. One of the ways too that Superior Health can be of help to you, I know that questions sometimes have come forward that we just cannot answer, nor can anyone in the crowd answer. So we at Superior Health have some folks that are attending meetings, as Eva said, with CMS, and then we can bring those specific questions that you have. How we get that back to you, we definitely put that information back into our resource list. So that gives you sort of an idea of how else this call can help you. Thanks, Eva.
This is Brooke, actually. I'm an administrator out at a skilled nursing facility in rural Minnesota.
Hi, Brooke.
Hi, we've been utilizing telemedicine, telehealth, nurse practitioner daily rounding, and psych rounds and skin. And actually, my understanding as well too, I mean, we're using them in between our MD visits. My understanding with CMS prior to all of this is as long as the physician is on site, you know, that's where they're looking at that on-site visit, or otherwise for us, I mean, it's not counting as an on-site visit, but it is billable through the contract, through the way that our facility has it set up. And I'm sure they're all unique. So just if that helps enlighten anybody, it's something that definitely is in the future. And I mean, we have a communication board. Everybody writes on the exact same thing if they see anything, any CNAs, LPNs, RNs. So then when that individual is going to be then seen, they can triage and just kind of be more efficient and quicker with things. So.
Thank you.
Yep.
And I will say that I think that what makes the future hopeful for telemedicine in terms of, because obviously in healthcare, everything's, always about, making sure the patient's taken care of, patient-centered care. And I think the one thing that this whole pandemic has done, if there is good that could come from it, is that it has opened the doors to kind of show the value of telehealth and allow CMS to, I think it's going to be very hard for them to pull back the doors that they've already opened. And kind of retract. So I think that there's going to have to be restructuring in terms of the allowance of telehealth. And I really think that in the next 6 months to a year that we'll really see a release of some of the limitations and restrictions on telehealth. Because I think the old notion of 3 years ago, 5 years ago, when telehealth was first introduced, that telehealth is to be used for remote locations only. I think that that's kind of a passé model. I think that we all on this call can agree that there's great value to telehealth in all settings. It allows for, as I call the Amazon experience when it comes to healthcare, now, this second, and everything gets addressed right in that moment, rather than waiting for a call back or having the physician see the patient the next day. And that's why there's results with telehealth. That's why you do see reduction in length of stay and reduction in return to hospitalization and reduction because everything's taken care of instantaneously.
Hi, Justin. This is Christy from Superior Health. I posted something in the chat that I'd heard from a nursing home that is struggling with this a bit because it's taking so much time. They said it takes like a full FTE of an RN because it's hard for the residents to always understand through their video system and much less handling the equipment and all of that. So the RN always has to be the intermediary. And I'm just wondering if you could give her any tips or anybody else on the call on, how to address these issues. Thanks.
Sure. So I will say it's a loaded question. So with our system, we always make sure that the nurses are well versed with it. So in the buildings that we've been in for a while, all the nurses are very comfortable with it because they're constantly doing test calls. We have a implementation specialist that's always following up with them. So they are very well versed with the machine. So in order to do a telemed call, it's basically just the time that it takes for the provider to do the examination. So, they may be on a telemed call for 7 minutes, 10 minutes, somewhere in there. And then, no different than if they were on a phone call with the physician or with the mid-level. In buildings that we do have that are have newly acquired our services, do the nurses struggle with it? They do at first. I would say for the first 3 to 5 calls, they have some difficulty. But again, I think that it's all about optimizing the time in which you do telemed calls. So we break patients down into 2 categories. So there's your acute visits that you're doing. So patients in respiratory distress, they need to be seen immediately. They need a telemed call for an assessment. So that's one split of our patient population. And the other split is just like, your 30 days, your 60 days, your H&Ps that you're doing, the non-urgent, non-acute calls. So I think that for the non-urgent, non-acute calls, what I would recommend to that facility is that they schedule them. So they say, okay, listen, I'm doing med pass at 9 o'clock in the morning. I'll be in Susie Smith's room at 9 o'clock. Can we do a telemed call then? So we actually have a calendar that the providers and the nursing staff are able to schedule on. So that's how we alleviate a little bit of that stress. As far as the acute visits, there is no real way to alleviate some of the stress that's on the nursing staff in doing that. Now, what I will suggest is that also some of the nursing managers have stepped in and helped as well. And, especially during this pandemic with the volume of patients that need to be seen during telehealth, it's kind of just been all hands on deck. But I will say that for that building, if they do schedule some of the routine visits, it alleviates a lot of the stress on the nursing staff and whoever's initiating the telemed call.
Brooke, too, I know it's been very beneficial for us in our facility previously as well, too, just for the fact that that we integrated our PCC. So we have a daily time every day at 10, and we have a list so they're aware, to communicate who we would plan to see. And then actually our nurse practitioner reviews our progress notes, any changes, and that's emailed to the director of nursing and myself in the morning. And then, it kind of gives us adequate time after clinical to, do that. But also we had not, isn't required for us with a nurse practitioner in long-term in our facility to utilize, we can utilize the right person. We choose to use RNs for when we do skin rounds, our weekly wound rounds and such, because they're the ones that need to document on our side. However, we all document in the same system as well too. So if you're short of hands, having that, knowing it's every day at the exact same time helps the CNAs know that they need to get so-and-so ready and available, and they can actually bring the individual to and from rooms and whatnot. Or, well, with this case, I guess it wouldn't leave rooms, but just, another tidbit too.
And Brooke, I'm glad you brought up wound rounds, because that's a great point. So what's unique about wound rounds, and obviously every facility does it differently, but at least with the majority of groups that I know that provide medical care and do provide wound rounds, is you often have one provider, one physician, one mid-level going to multiple buildings. So I think that we've seen an extreme benefit to wound rounds, because limiting, again, the single provider going into multiple buildings and either going from COVID positive buildings to COVID negative buildings and being a carrier. So we have also initiated that as well through telehealth in order to not have that provider carrying it from building to building. So I do agree that telehealth has been a great assistance in completing wound rounds without exposing the building unnecessarily.
This is a great example of you sharing evidence or sharing best practices. That's what we're here for. So keep it up. This is a great conversation. Thank you. I do happen to be looking at the polling, just kind of getting a feel for who's in the room today. And it's, for the most part, a lot of nursing home facilities are on. Thank you. So happy to have you here. Hospitals are here greatly represented as well. You two work hand in hand often. Then there's a smaller groupings of a few other folks, but all part of the team. One of the groups in the team today that I just want to put a shout out to, if you were not on the call last week, EMS, there were a few questions, and I know that we went out to seek the answers to those questions, but we're glad to see you here today as well. Continue to invite others to get to this call. Elena, is there a way, can you tell them how to invite others to this call in future times?
Yeah, so we did send out an invitation that you likely registered for this call. You can feel free to forward that along to anyone else that you may want to invite. I believe we will be sending out an invitation again. Is that correct? Can anyone from our community? Bev?
Yeah, this is Bev, Spirit Health. On Tuesdays, we plan to always send out the invitation, which will also carry it with it the recorded calls and all of our notes. So if you follow that link, you'll get to all of our resources.
And so in there, they can forward that to others so that new folks can join?
Yeah, please do.
Okay, great. Great. That would be helpful to all of us as well, to have you invite folks, because there are areas of the team, of the full, healthcare team within a community that aren't necessarily represented. So everyone can be a support of each other. We have, as I mentioned, a resource list. Elena, did you want to talk just briefly about some of the updates from that list from last week?
Yeah, and I'm actually going to share on my screen. One of the things that was asked for last call, which we didn't have, was kind of how to minimize risk of COVID-19 for you and your loved ones at work. And someone from the Wisconsin Hospital Association actually shared this resource in a collaborative they are in. And we wanted to share it with you. It is included within our links of resources. Are you all seeing this? University
Yes.
of Michigan? Okay, perfect. So the only thing was we couldn't find it on a website anywhere, so it is on their Twitter. But it's a really great resource. It does kind of show you before work, during work, after work. So we did want to share this with everyone to let you know that there is a resource out there that kind of does give a pretty good overview of some different strategies that your staff members could take to minimize risk of COVID-19. We also noticed on their Twitter account that they do have a couple other really nice resources, like this one about before and after going grocery shopping, and I believe there's one other, talking to your family about COVID-19. So there are some pre-made resources. They are University of Michigan surgery branded, but we did see these out there and we did want to share them with you in case you did want to kind of use them in your own facilities, maybe take some things from those to share with your staff members.
Definitely share them far and wide. I know that in my personal experience, I have a house full of public works workers and neighbors who go out as firemen, as those who are fixing our power lines. I've asked them to take a look at these guidelines so to keep us safe, because they are essential workers as well, not on the front line as of you, not touching patients necessarily. However, as we all know, we don't necessarily know when we are up against someone or near someone who has the virus. Thanks, Elena. I also wanted to mention this week we did find a couple of resources that we want to show. Also, just we're hoping that you are being supportive of yourself. This is a great deal of stress on everyone, but I cannot even imagine being there on the front lines, listening to the various opportunities that you've have to create new processes and practices, and I'm sure sometimes it's clearly on the fly. So do please take good care of yourselves. One of the resources that we have added to our resource list that will come out after the call is from the American Medical Association. They have an excellent list on their website. And also we are passing along a guide from NAMI. NAMI, as you know, is our national mental health group from nationally providing us with resources. There are local chapters, just so you know, in each state, as well as sometimes even more local, more specific chapters around your various counties. So please take a look at those resources. Those are things that could really support all patients as well as yourselves. Before we get ready to close today, are there any other questions that are in the chat, Elena?
I do know we got a couple of comments, and I know some comment was, depending on volume in a facility, we as a health system are offering to send in an RN to a telemed visit with scheduled. So I just want to let you know about that comment. I know that there are a couple of our Superior Health team members that had a couple questions. If either of you think that you have enough time to kind of ask those questions, please feel free to do that.
Mm-hmm. Go ahead.
Hi, this is Janelle, here from Superior Health in Minnesota. I had a question from one of our health systems who's unable to be on the call today, so I'm asking on behalf of them. She's wondering if anyone knows of any modeling for other states regarding the number of hospitalized COVID patients that require a nursing home stay post-acutely. They're trying to figure out how many post-acute beds they may need once they get the surge, so we can partner with facilities that have designated units for COVID post-acute care. They'd also love to see if there is any data about length of stay, both acute and post-acute for COVID patients based on cities that are further into this than we are here in Minnesota.
Thanks for the question, Janelle. Does anyone in the call have any resource or understanding of this? Is there anything in the chat, Lena, about it?
Not currently.
I don't know if this applies totally to the question, but my name is Sarah. I'm in Michigan, and we deal with one of the large hospital systems in Detroit. And we have a daily huddle every morning for 15 minutes where the head of the post-acute care meets with, first she does the sniffs, and then she does the other community members and the home cares and takes a poll of how many beds they have open, how many COVID positives they'll take, how many non-COVIDs they'll take, and what the availability is in all the areas. And it's just a quick, I think it takes her probably about an hour, but for each facility, it's only a 15-minute call. And then it updates through the system how many patients are in the system, how many patients are ready to be released, and to what type of facility.
Thank you. It's very helpful.
Elena, I think the call information just shared also kind of answers the question related to how do you respond to hospitals testing individuals and then sending the resident back without a notice. Encouraging you to find a way to communicate and develop some type of weekly check-in with your organizations. I know in previous calls we've shared transfer forms that have been approved here in Michigan that were adopted from Florida as well. I would strongly encourage you to maybe even share that transfer form and communicate with your hospitals and organizations in seeing how they can utilize these transfer forms to better protect and share that communication.
Thanks, Eva.
Thank you. All right, so we're coming to the the end of the call time. However, we do have this slotted on your calendars for an hour, and that is so that we have an opportunity to continue with the conversation and not just abruptly cut you off. And you may have some additional questions. So feel free to chat in for a few more moments or even open your line and ask a question. We're still here and available to you. For those of you who need to move on and get to your rest of your day, again, we so appreciate you. And we are hoping that you're going to take a look at the resources we provide for you from NAMI. as well as the resources we provide for you from American Medical Association. Excellent lists. Take time for yourself. I think, you know, in the coming days, it's going to be needed. Elena, anything more coming in?
We did get another question in the chat. It comes from Arlen Swanson. Does someone have a nice protocol for hand-line, handmade masks?
That's an excellent question. I know that has gone around and around communities. And it's been a, you know, the lift has been, you know, that get what you can at this point in this difficult situation. Anyone have any resources they feel are good to utilize? Anyone from Superior Health that know a direct link perhaps we can point folks to?
This is Julie Bannister with Superior Health. Are you looking for disinfection processes, or are you looking for the effectiveness of the masks, of using the cloth masks?
It looks like it's not obtaining, but washing and taking home, leaving facility policy.
Thanks. We'll be happy to look into that for you.
Yes. Great question. Anyone else?
We do have an extra comment in the chat from Sarah Blackstock. She says, we let our home care staff wear them over the top of other masks if they want to. They are required to wash per CDC guidelines.
Okay. Excellent.
And I also saw that Eva did put, for that question about testing individuals and then sending the resident back without notice, Eva did put the link to the transfer form that was created here in Michigan, if you wanted to take a look at that.
This question is for Sarah Blackstock. This is Julie again with Superior Health. Thank you for talking about the hospital system that's working really, really well with the SNFs and the home health agencies. Can you talk a little bit about what you know they are doing with CarePort as far as communication between SNFs and the hospital?
Hi, they do have an integration with the CarePort, and they have a COVID questionnaire. Our software is not integrated yet, so I don't know what's all in there, but I can see if I can attach the little webinar that they sent out for the directions on how to do it. And they have, there's a questionnaire and some other integration on testing that goes along with it.
Terrific, thank you. I wasn't sure from the calls if they were using that as a way to talk about residents who were positive, who had tested negative, when they could transfer them. I wasn't sure if you had that information. Thanks.
I don't yet, but there is a lot of, they do have like a survey in there. I'll see if I can pull it or have Gloria send it to Barb, who can send it out.
Thank you.
Thank you very much. Excellent help. Are there any other questions or comments or recommendations?
Eva also put into the chat that a guide from the CDC on face masks to kind of help with that question from Arlen.
Great, thank you. All right, anything else, Elena, that you're seeing?
Nothing new in the chat right now.
Okay, so I want to remind everybody that, you know, we are here. Superior Health, we are, you know, here with you. Again, we can't stand next to you on the front lines. However, note that we are here to look for things for you, provide some resources, perhaps network you with others who may have similar situations going on. So please do reach out beyond this call. Start collecting your questions for next week. start talking with your staff and ask them what are the questions they may have that you could bring for them. Or if you can't be here, as you heard a few times, some of us had brought questions from folks that we are connected to. We wish all of you well, and you know, we hope that your next week goes well. Please join us again next week. We thank you for attending today.
Thank you.